I am sorry I don't speak your language, and in fact the British people think I do not even speak English. I speak American. And my own opinions about diabetes. When I talk to our medical students at Johns Hopkins, the main message that I try to deliver to the students before they graduate from medical school and become doctors is that diabetes can be controlled. That there is not necessary, it is not necessary to have complications of diabetes. But diabetes, if it's not controlled and not taken care of, there are very serious complications, for diabetes that can affect the eyes and the heart and the limbs and the nerves and the kidneys. So the complications can be very severe, but if the diabetes is well taken care of and well managed, it does not have to occur. So we consider the management of diabetes to be a team effort to control it. They should know about the importance of a good healthy diet and of activity and exercise in the course of their day. They should know about what the blood sugar means and what the blood sugar should be, what good numbers are, and they should work with their doctor team. And in the United States, we're with diabetes to try to take care of diabetes. And I must say that with the ministry here, I would say it is also a partnership with the society and the government to help take care of diabetes and to help get the message out about information about diabetes, how to management. Whether it's for coverage of necessary supplies, in other words, payment for necessary supplies and insulin and so on for diabetes, or whether we even in the United States sometimes have discrimination against people with diabetes so that they have trouble maybe getting a job or getting the right kind of job. And so we, in the American Diabetes Association, we try to advocate for the rights of people with diabetes to have good employment, to have no discrimination. So those are the sort of things that are at the public health level. And then at the doctor's level, we do try to work. Whether any of you know about A1C? Have any of you heard of hemoglobin A1C as a test? Everybody knows. I won't ask how many people know what their hemoglobin A1C is, but there are a number of people that there are a number of ways to follow diabetes, and hemoglobin A1C is one of the most important. In fact, it was some years ago, but it was in 1976 when I was part of an article in the New England Journal.
And the first question is from the Honorable Minister.
Dear Dr. Saudek, that we have heard you have your own research going on, mainly focused on developing an artificial pancreas. How far you have reached in this?
Like transplantation, maybe transplant of islets, maybe stem cell research someday could cure diabetes. Or I think of diabetes being cured by a mechanical approach, an engineering approach, a device approach. And our own work has been with the device direction. We have worked with insulin pumps, and we have worked some with insulin, with implanted insulin pumps. Now, the artificial pancreas, a final cure through an artificial pancreas, would require really three parts. It would require a delivery system, sugar, minute by minute. And the third part would be to have the algorithms for a computer to link the sensor measurement of blood sugar with the delivery of insulin, so that you would get insulin only when you need it. When the blood sugar goes up, the insulin would come out, and when the blood sugar comes down, the insulin would stop. That would be the perfect artificial pancreas. Now, where are we now, you ask? We have done our research work mostly with insulin pumps, and in fact with implanted insulin pumps, so that we have a device that is about the size of this, let's say, a little bit bigger than this, about the size, of a hockey puck, ice hockey, but it's about this big, and it's implanted under the skin by a surgeon. And then once they do that, then the patient will carry a little controller, which is about that big. And with it, they can send a message into the implanted pump that says when they need more insulin, when they need less insulin. So it's like an external pump, but it is all the way under the skin. And it's controlled by radiotelemetry. And we have been working with these pumps for, in fact, 15 years now. And the pump that we have now implanted in about 10 patients has a life expectancy of about 8 years. It's supposed to last 8 years. We'll see if it really lasts 8 years. So far, about 2 years. We refill it, the reservoir, every 3 months with a little needle that goes through the skin. And I do that. I just use sterile technique and scrub the patient's abdomen, go into the pump, and pull the old insulin out and put new insulin in. And that lasts for about 3 months. So they don't have any more injections for that period of time. Now, that does not have any glucose sensor. So it does not measure the blood sugar. It just requires the patient to measure their own sugar and to tell the pump when to deliver insulin. So that is where we are now. We're working also with some sensors, which is another story, but we are not at the level where we can make this an automatic pump that delivers insulin all the time. So that's more or less where we are. We're with what's called open loop implanted insulin pump. We also have a lot of patients that use external pumps, which are worn on a belt or kept in a pocket. And there is a external pump, which is one that we have a lot of patients using also.
There are
Yes, this is on now. Is this working? 1, 2, 3. Okay, this is working. There are more people in India with diabetes than anywhere else in the world. When you look at the international statistics, India, unfortunately, is the leader. There are more people here than any other country in the world. And worse than that, it's going to get worse in the next 20 years. So that India will stay, we think, the leader for number of people with diabetes in the world. China is second, and the United States is third. Now, it's interesting and it's too bad that people in Asia, whether it's in India or in China or in Japan, all have a, if you deal with BMI, that's the body mass index, in all throughout Asia, people with a BMI of over 24 tend to get diabetes. Now that's much lower than in Europe and in Euro-Americans. So that's partly explains the problem in India is the genetic tendency to get diabetes even when you're what Americans would consider very thin, not even obese or very overweight. So there is a strong genetic part of this. And unfortunately, the genes in Asia tend to develop diabetes, cause diabetes when the body weight goes up even a small amount. Now, there's a lot of family history also. If you have a lot of diabetes in your family, you're more likely to get diabetes. But what can be done about it, of course, is to avoid becoming overweight, and to stay active and have a regular exercise period. That's the best thing that can be done. But I think of diabetes in an odd way. Diabetes is a disease of prosperity. And so when a nation comes out of being undernourished and begins to feed its people adequately, the people, of course, are not that. And the old information I had was that maybe it's caused by the cassava and by tapioca. But they said there's not good evidence of that. So maybe that information is out of date. I'd have to ask the more up-to-date doctors about that. But I do know that there is a pancreatitis that can cause diabetes, particularly in Kerala.